Whether you're a rider, groom, owner, or simply obsessed with all things equine, this podcast is for you. The curious, the dedicated, the horse geeks. Each episode brings you behind the scenes of equine veterinary medicine with expert voices from Netherlands, Pferdekliniek, and beyond. We dive deep into the science and practical know-how that help horses thrive. This is your trusted source of equine knowledge, straight from the people who live it every day. Learn more to care better. So we are back with Professor Derek Knottenbelt, who we will today talk about the sarcoids. If we start from the beginning, what is a sarcoid?
Therein lies a tricky business. Historically, it used to be termed a wart. Everybody was wart. And that, we all know what a wart looks like.
Yes.
But if you see a wart on you or on any other animal, and you see a sarcoid, there is no similarity whatsoever. A sarcoid is a form of skin cancer that derives not from a change in the cell structure itself, inherent structure, but from the acquisition of a small particle of a papillomavirus. And that gets into the cell. It's a fibroblast. It's a tumor of fibroblasts. It's nothing to do with skin surface or anything like that. It's a cell which lives inside the skin, the fibroblast, and when we realize that, we realize it's a lot more complicated than it actually looks from outside, and they tend to be locally invasive. But fortunately, they do not spread to internal organs. The sarcoid is a potentially locally malignant tumor. In other words, it penetrates into the local tissue adjacent to where the tumor is found initially, but it does not spread by the bloodstream or by the lymphatic system into internal organs. There's no recorded case of that whatsoever, and that's simply because it isn't a mutational tumor. It doesn't mutate from one stage to another, because what you've done is to put inside a little time bomb, I suppose.
Yeah.
Gets put inside the cell, which converts its behavior into a hooligan. Okay, and then of course you get the consequences of it. So it's a tumor of fibroblasts, but it is a form of cancer.
Okay, and where does it come from? So you mentioned from the papillomavirus.
Yeah, the bovine papillomavirus is seemingly the main cause for it, because I suppose historically this aspect of it was found by a pathologist called Jarrett in Glasgow in the mid early 70s or late 60s. I think he was doing the work and published it around 1970, where he identified that the bovine papillomavirus was involved here. And then, of course, everybody thought of it as a virus disease.
Yeah.
In other words, now it becomes, oh, hang on a minute, this is a virus and it's going to spread like a virus.
Mm-hmm.
Doesn't do that.
No.
It simply doesn't do that. And it's a lot more complicated than that. It's only a little piece of the virus which is the cause of the problem.
Okay.
And so the virus doesn't multiply on the horse. It's a bovine papillomavirus, comes from cattle. Yeah. Okay.
Yeah.
And if you take that papillomavirus and inject it into the skin of a horse, you get what's called a pseudosarcoid. It's a tumor that looks like a sarcoid, but it gets bigger, and then suddenly the immune system of the horse remembers it, says, hang on, I don't want this, and gets rid of it.
Okay.
And so they all resolve. If you take the genome that is responsible for it and inject it, then you don't get any of that. You just get what we know of as a sarcoid.
Okay.
And that transmission work was done through the 70s and 80s or thereabout, where we would take bits of the sarcoid and transfer it from one site of the horse to another, and of course you just got the same thing growing again. So that is exactly what would happen with a tumor, particularly if it was a fibroblast tumor. And we remember that the skin contains 13 different cells, of which fibroblast is one of them.
Yeah.
Okay, and these 13 cells all have their own cancers. So there are cancers, genuine cancers of fibroblasts, fibrosarcoma, for example, that are different, and those are mutational tumors, but not insertional tumors like the sarcoid.
Okay, and how common are sarcoids in horses?
Wow, that's an interesting question. In 1972, I think 72, I did a little survey, and in amongst the stables around and about, and I found that 2.5% of horses had approximately 2.5 sarcoids each on average.
Okay.
Of course, an average doesn't mean a lot.
No.
Because if I put one of your legs in the freezer at minus 40 and one of your legs in the oven at 200 degrees, on average you're very comfortable.
Yes.
So the two extremes don't really much matter, you see, but at least it gives an index of something we can measure.
Mm-hmm.
So I did another one just before I retired in 2009, where I found that 8.5% of horses had 25 sarcoids each on average.
Wow.
So that shows that there's been a rise in the incidence of sarcoid in the population of horses, and that is certainly true. And the reason for that is not clear. I think it has something to do with the flies, which I believe to be responsible for transmission of the disease. It may not be as simple as that.
Mm-hmm.
We don't know, in truth, we don't know that yet.
Mm-hmm.
But I think we have to have some hypothesis at least where we're saying this is likely to be something involved with it, because we stopped controlling flies around then.
Okay.
Because we don't spray stables with chemicals to get rid of flies. We just let them go.
Yeah.
And because that's part of our wildlife world.
Yes. Also very hard to
and it's very
to keep
hard,
track on.
Absolutely, and it's very difficult to keep a track of them. So I think it's by far and away the commonest tumor of horses, by far and away, of all. And of course, it is by far and away the commonest cutaneous tumor of horses by a long way. And because you can see it, it should be recognizable, and we should be able to do something with it early.
Yeah. But where do they usually appear?
That's another issue that is important, because the one place we don't see, I suppose it's more in the negative than the positive.
Yeah.
They don't occur on the back of the horse, on the back and the buttock region, for the most part anyway.
No.
I've seen one or two there out of, I don't know, a lot of sarcoids. I've dealt with more than 150,000 cases through my service anyway, and I look at them and we try to analyze them. But where they occur is in where the skin is very thin, where there's limited hair, where the horse sweats without difficulty, and where flies can feed without being repelled. And that is in the armpit regions, around the eyes, around the base of the ears, the sides of the mouth, and in the groin region, round about the mammary gland, and around the sheath and the penis of the horse. And all those areas are where those criteria are most prevalent. Beyond that, sarcoids occur at wound sites. Now the question is, the wound does not have to be big. The wound can be microscopic. And therefore, it might even be the bite of a biting fly, a blood-sucking fly. They don't transmit the disease, the biting flies, but they create the wound into which the sarcoid element, whatever you believe that to be yourself, it could be a virus, or it could be part of the virus, or some other thing that you might think of that I don't know anything about. I'm not pretending that this is necessarily the gospel, and it may not apply at all in the end, but at least at the moment it is a reasonable hypothesis that then the surface feeding flies feed on a sarcoid, either on that sarcoid over there on that other horse, or on another site on the same horse, and then they sit on this side, because that's how surface feeding flies feed. They like to go to wounds and things open. and then they may transmit it into there. Now, just because they may carry the viral component or the virus, whichever way you want to look at it, it doesn't mean necessarily that the tumor will grow.
No.
It's only just a few that do.
Yeah.
And that's why they occur in these sites. So where they occur on the distal limb, for example, around the coronary band or the fetlock or the knee carpus and around the knee or around the hock region, these are almost always incipient causes of wound healing failure.
Okay.
And of course the wound doesn't heal. And it
Yeah.
doesn't heal, and it doesn't heal, and it doesn't heal. And you do all the things that are supposed to make a wound from heal, but damn me, it doesn't heal.
Yeah.
And it doesn't heal, and it doesn't heal, and everybody panics. And then you take a biopsy and, oh dear, it's a sarcoid.
Yeah, okay.
And that's a problem.
You mentioned early intervention, so how do you actually spot the sarcoids in an early stage?
Well, I think that there are some signals.
Yeah.
Because it's a tumor of fibroblasts that has a genetic expression that relates to papillomavirus, it will change the behavior of the surrounding keratinocytes. Of course it does, because it expresses mediators that diffuse out. And so the first signs of a sarcoid are usually a change in the hair color in a circular fashion with a little hairless area in the middle. Or if you pick up the skin a little bit and run it between your fingers like that, you can feel little gritty bits inside, little balls growing inside. Of course, every single tumor starts out as a single cell.
Yes.
It doesn't start out as billions.
No.
It starts out as one. And so they gradually get bigger. But if you can see these hairless round areas, often, interestingly enough, associated with blood vessels, either on the inside of the thigh, where there are lots of prominent blood vessels in the horse, or on the armpit, or around the ear or the eye, where blood vessels are prominent and on the surface.
Are they feeding off the blood vessel, or?
No, they don't feed off the blood vessel. They feed off the wound that is there, because the flies feed on the blood over the blood vessels.
Okay.
You see the biting flies feed over blood vessels. So you can see how this link seems to satisfy. It's a hypothesis. It's nothing more. This is not proof. This is not anything. It's a hypothesis, but it seems to provide an explanation for the whole epidemiology of the equine sarcoid.
Yeah.
You can't treat it as a virus blowing around on the wind.
No.
Because why should it develop in the inside of the thigh, preferentially if it's blowing around on the wind?
Yes, and why wouldn't it then infect every horse?
And why? Funny you should say that.
Yeah.
Why doesn't it affect every single solitary horse?
Yeah.
And that leads us to the fact that there are some horses that are genetically predisposed toward the disease, and some horses that are genetically resistant to the disease because they don't have the genes that impart susceptibility. And these are, in my opinion, genes for genetic susceptibility, and there's more than one of those. We don't know how many, but there may be 3 or 4 or 5. And so if a horse has one gene for susceptibility, it may have mild disease. If it has 2, and so on and so forth. But the problem is, if you treat it like that, a significant proportion of the overall population of horses seems to have the genes that impart susceptibility. So 60% or more may have genes that give some form of susceptibility. And it's quite complicated because you may have to have this gene, gene A, before you have any susceptibility relating to gene B, C, D, and E. Having a gene E on its own doesn't help at all.
No.
And yet you can detect that gene and say it's got a gene for sim, but it may need the others or one or more in some combination that we don't understand.
Yeah.
And I've had to think of these hypotheses. They're all hypotheses. I'm sorry about that.
Yeah.
It's just I don't think the current explanation is good enough.
Yeah.
And I think it doesn't apply. I mean, humans have a BRCA gene.
Yes.
The BRCA gene imparts susceptibility to some forms of cancer, breast cancer, prostate cancer, cervical cancer, so on and so forth. in one form or another. And so if people have that, doesn't mean they're going to get those cancers.
No, but they're more likely. Yeah.
Okay. So as far as that's concerned, then people have said, well, all right, the virus, and that led us to the concept of a vaccine that we were talking about earlier.
Yes.
People say, well, you can vaccinate children against papillomavirus, and they don't get cervical cancer. I mean, boys get vaccinated as well. Sure, they do. And that, of course, protects them. But of course, that's a very different circumstance from the sarcoid.
Yes.
See, that gave an idea of a flood of information. Oh my God, we've got the solution. We just make another virus vaccine like we've got for papillomavirus for people. We just make it, and sarcoids will all be protected. Unfortunately, it doesn't work like that, because it's not like that.
No.
The disease isn't immunogenic, and therefore, and furthermore, cervical cancer, for example, is an epithelial tumor. It's a cervical carcinoma. It's a squamous cell carcinoma. And that is a very different thing from a fibroblast tumor, which is an internal mesenchymal cell type.
Yeah.
So you can't treat them in the same way.
No.
It's impossible to do that. And we should get away from the vaccine story, because in my view, it's irrational.
Yeah.
And certainly there are very few documented reports of success. I fully understand why people do it, and that's why they do it, because that's the concept that's put out.
Yeah.
But unfortunately, it
doesn't work.
It's not working.
Yeah.
And if it is working, publish it. Let's see the publication. Let's see what we can do, and let's crack the code of this disease, because it's getting out of hand.
Yeah.
It's getting out of hand. I mean, we often we're often presented with hideous cases, absolutely, cases that you would not believe would be existent. And I thought, when I started out dealing with this 57 years ago, that we would eliminate those, and we would start dealing with early cases. But we're still presented every day with hideous cases, absolutely hideous. And you say, what's gone wrong here?
Yeah.
When our case has got cancer for years, I mean, if we had cancer for years, what do we expect?
Yeah.
You're not going to recover. You
no,
deal with
for
it
sure.
when it's small.
Yeah.
You don't deal with cancer. That's why that early recognition that you were talking about is a critical issue.
Yeah. But so then that brings us actually to the course of treatment.
Yes.
Because I think being in stables all over, we've all seen people say, oh, just put a rubber band on it, or put toothpaste, or all of these things that are actually not very clinical, I would say. But how should we treat the sarcoids?
Well, it depends where they are. There are criteria that we have to, when we're making a decision for treatment, we have a series of 12 decisions that have to be made. And the list, of course, involves the type of sarcoid, the location of the sarcoid, the extent of the sarcoid, the degree to which the sarcoid affects the horse. So it's the type, the location, the duration, what's been done before, and the prognosis. So there's 5 or 6 things that we consider primarily. And then we have to say, what's available? Yeah. Because regrettably, there's no commonality of what's available. And so what's available in Switzerland is very different from what's available in France, or even across the border in Germany.
Yes.
You see, and even within within 1 meter, which is the border width.
Yeah.
There's such an enormous difference in what's available and what can be done. So there are 40 different treatments that I have looked at over the years, and this involves a panel of surgical treatments. We can do surgery, we can do ligation, which is what you mentioned, putting a rubber ring around them. Of course, it doesn't work, and the reason it doesn't work, unless you're very, very lucky, sometimes you're very lucky because there isn't any roots on it.
Yes.
So when you look at a sarcoid, what you see
it's
is
just
the
the
palm
tip of the
your
iceberg.
hand,
Yeah.
What you see, what there is your fingers, and that they go in every which direction away like a hedgehog in reverse, if you get my drift.
Yes.
See, so then you have to get to every single one. So if you put a rubber ring on it and you leave some cells behind the rubber ring, okay, A, it's coming back, but B, all the blood supply that went to the whole tumor now goes to the bottom, the bit at the bottom, and now it's spitting mad.
Yeah.
And that's a well-known phenomenon for all cancers in all species, that if you interfere irrationally, the tumor gets angry and comes back worse than ever.
Yeah.
Okay, and so surgical methods, these kind of things, sharp surgery, laser surgery, diathermy. I used to use a harmonic scalpel, plasma knife, all the sophisticated surgical things. You can use all of those, of course you can. But how do you know you've got the whole tumor? Do you see? And if you don't have the whole tumor, what is the likely consequence? Likely, not certainly, but likely, the tumor itself will come back worse than ever. Worse than ever. And you can't allow that to happen, because what is growing underneath you don't see until it's too late.
No.
You can't, because it's cut off and everything looks fine, and meantime what's going on underneath is growing and growing and growing. Says any minute now I'm going to rush for the surface, and then whoosh, it comes to the surface. Then, oh my God, this is a terrible state of affairs.
So actually it can grow really fast.
Absolutely.
There is no
Absolutely.
there is no general timeline actually on how it works.
Absolutely not. No. Absolutely not. I've seen tumours that have stayed static for 30 years.
Yeah.
And I've seen tumours that have erupted within days.
Yeah.
From tumours either interfered with or not interfered with.
Yeah.
So it's such an unpredictable thing. And I think mostly that's what's triggered the previous rather lackadaisical, rather laissez-faire, leave it alone, it'll be all right.
Yeah, because the more you poke it, the more it comes.
Yeah, it's like poking a tiger, isn't it? It's okay until you poke him extra.
Yeah.
And then suddenly he's not happy with you, and that's it.
Yeah.
Do you see? So the reality is that as far as these surgical treatments are concerned, you've got to be very careful, and you've got to send the samples off for histology, because that's professionally, in my view, professionally obligatory. It should not ever be left without the histology, because you have to know. It protects the patient, firstly, and that's the most important thing.
Yes.
It protects the surgeon, that's the second thing.
Yeah.
And the third thing is protects the owner.
Yeah.
And of course, fourthly, it protects the profession, because this is the right and proper professional thing to do.
Yeah.
What would we do if we had a tumour cut off ourselves and they said we weren't going to bother with the histology?
No.
We would be horrified.
Yeah.
Horrified.
Yeah.
And quite rightly so.
Yes.
Doctors would be struck off if they did that. Actually.
No, for sure. For sure.
Would. But we say, don't bother. It costs 50 francs extra to have the pathology. But when you consider what it's costing to remove it anyway, and what the cost of a recurrence is, 50 francs looks stupid.
Yes, absolutely.
So
but it goes back to to doing something thorough at an early stage rather than waiting it out.
Absolutely, absolutely. So that's a surgical. There are a variety of surgical methods that individual people do, but I'm trying to encourage, because of the risks, people to use surgery plus concurrent chemotherapy. So you remove the tumor, then you infiltrate the area with some chemotherapy, and then you watch for the for the histology report to come back, and then you take some action accordingly. So you move your action with the information. You carry the information into the action. Okay. Yeah. And that enables you to get better results. Not perfect. No cancer ever is, unless you read the internet. Yeah. There is no cancer in the world that has documented 100% success rate. No. Not even one. But if you read the internet about the sarcoid, as you so rightly say, there's toothpaste as a 100% success, and some of the nonsense that I see, all sorts of rubbish that's published, turmeric paste, this is cancer, they say this sorts out cancer. Well, why do people who eat curry still get cancer then?
Yes.
If it was that good, which it is not.
No, if there was evidence that it would actually cure it, then it would already be there. Yeah.
Absolutely. So I just think, we've got to get some rational chemotherapy. We've got to develop chemotherapeutic agents that we can use in conjunction with surgery, because if you want to improve your 60% overall surgical prognosis, and I know somebody listening to this is going to say, this is rubbish because I get 100%. And that's fine, but if he is getting or she is getting 100%, then she should put her data in the publication and tell us how she does it.
Yeah.
Because that's what has to happen, because we have to learn from that circumstance, and we have to make the best of it we can. But I've done more, I've supervised the treatment of more than 155,000 cases of this disease, and I know that to get 100% success is impossible. And therefore, if you haven't got a failure yet, you still haven't done enough. Or you're being very selective about the ones that you do.
Or very lucky.
Or very lucky, or all three of these combined.
Yeah.
And we all need a bit of luck in our lives. But if you happen to be Irish, I suppose, when people talk about the luck of the Irish, they may have 100%, but that's because they've got all sorts of shamrocks and things which give them benefit. So that's the combination of surgery and chemotherapy. And chemotherapy can be used on its own. We've got lots of new chemotherapeutic agents, carboplatin, 5-fluorouracil slow release, mitomycin C implants, these kind of things. Topical mitomycin C is not the greatest, but it's AA is used anyway. But we've just got to be very rational about what we are expecting these treatments to be able to do, and some of them are able to do a lot, and some of them are not able to do very much at all. Some of them are adjunctive and can be used in alongside others, like surgery or cryosurgery or whatever, and that's good. So that's the chemotherapy, and there's lots of agents for that now. There are some. Then we've also got immunotherapy, and that's very interesting because that uses the body's own immune system to target the cancer cells. I mean, cancer only exists because your immune system fails to recognize the tumor cells. Not because your immune system is bad and impaired, but because the cancer cell protects itself. Yeah. So you can't improve your immune system to say, hang on a minute, I'm going to be able to recognize these things which are in camouflage, because they just make a new camouflage. Yeah. So the cells hide themselves. There's a sort of scientific receptor mechanism on the surface that blocks the MHC receptor, and when that happens, it doesn't matter how good your immune system is. It doesn't make any difference whatsoever.
No, and they will still find a way.
In order to make it recognizable, you either have to change the cell completely, or you have to stick something onto it. So whenever a cancer cell develops, he carries two little flags. I am your friend. And the other one's, so the first flag, I am your friend. The other one, don't eat me. Okay, so every time the immune system sees these cells, it just walks past. I mean, it's a facile way of looking at it, but at least it's illustrative. It's what I tell owners all the time. Okay, and so when you come for therapy, you have to say, how can I change the don't eat me for like a paint out, put a sign over it, a sticky label on the
and
don't.
Come and get
so
me.
Now it says, eat me. Eat me, you see. But the other flag's still there. It says, I'm your friend. So one kind of treatment is not really enough because the immune system says, oh, do I do this? Or hang on, this, he says, I'm your friend. How can I eat my friend?
Am I attacking myself, or
exactly right? So these don't work very well. But in combination, if you can combine that with something that says, inserts into the cell, I am not your friend, and you combine immunotherapy with chemotherapy,
Then
Done.
Yeah.
I am not your friend, eat me.
Yeah.
Dead. Cell out.
Yeah.
Straight away. Everybody's looking for that.
Yes.
In all cancer.
Yeah.
Every single thing wants always the same thing. To make the immune system see every single cell. Because if you make the immune system see every single cell,
well, then it takes care of it.
absolutely.
Yeah.
Now that tallies with the 1 or 2 sarcoids that respond, that resolve on their own completely.
Yeah.
I've seen sarcoids, confirmed sarcoids, that were histologically confirmed, that then we say, oh, well, look, we can't deal with it right now because the horse is going to Olympia or going to the Olympics or going to
And then they
something.
just disappear somehow.
And then 6 weeks later, where's the tumor?
Yeah.
Oh, it's gone. It just disappeared one day. You see,
Yeah.
those horses are immune for the rest of their lives. So there is, you see, a little secret somewhere. I think I've seen it.
Yeah.
And I know what it is. And we just need to be able to find a way of triggering it. And that's why some of the bizarre, stupid things work.
Yeah.
Every now and again, putting toothpaste on the tumor triggers this little change.
Yeah.
Now, why does it do that? It's not consistent.
No.
And it only does it once in a million or whatever it is of horses that get toothpaste or Vegemite, Marmite, this beef spread in Australia, or turmeric paste or tea tree oil and all these kind of things that people put on. It every now and again it just triggers that same thing, which is the spontaneous resolution syndrome, either of an individual tumor or more particularly over the whole body. Those animals are singularly resistant to even though they've got all the genes for susceptibility, still resistant.
Yeah.
Now, and that's because their immune system knows what to look for.
Yeah.
It doesn't making the immune system so good and so strong that it is going to obliterate everything, because it doesn't make any more recognizable. It now converts the immune system and say, hang on a minute, when we see that, we're still going to kill it.
Yeah.
Do you see? And then they go better.
Yeah, but so you've seen the mechanism basically. So how close do you think you are to solve it, or the veterinary?
I'm retired.
Yeah.
I'm retired.
But the veterinary field, how close do you think they are to solve it?
When somebody wants to talk to me, I'll be willing to talk to somebody.
Yeah.
Because at the moment, all the research is still looking for viruses, looking for vaccines, looking for things. I don't think it's the right way to go. And I'm viewed as a bit of an outlier. I'm a bit of a nutcase. And maybe it is. Maybe I'm wrong.
Yeah.
Maybe I'm wrong,
not.
But maybe not.
Yeah.
And absolutely. And my hypothesis answers pretty much everything we need to know about the epidemiological status of this disease. It explains why there are 6 different types of disease. It explains why there are some which are more easily treated. It explains why some spontaneously resolve. It explains why they all exacerbate. It explains why there's no immunological recognition, no marker that we know of within the blood. It explains why it's nothing to do with a virus and we don't have virus seroconversion. It explains it.
Yeah.
It explains it. Whether it's the right thing or not is another matter, but that's what I've put up as an option. You know, and it's only meant in that framework.
Yeah.
And I know there are lots of people working on the disease across the world, and no doubt they will come up with answers. But since I've been interested in it now for 57 years, I don't think that there has been enough blue sky thinking. There's no blue sky thinking. It's all goes back related to the original work about the virus and so on and so forth. And I think we're barking up the wrong tree. You know, this is not the way to go.
I need to widen a little bit the scope.
We need to widen our minds to alternative suggestions for this disease, because what's the current dogma does not explain the disease.
Yeah. Well, if they haven't found a solution going down that road, then we might need to go down another road.
And then the gold standard treatment is radiation.
Yeah.
That's unfortunately becoming less and less and less available. The place in France doesn't do it anymore. There's one in Germany. They're reluctant to do it now, I think, with the HDR radiation.
What is the reason for the being reluctant to it?
They don't want to do it on horses.
Yeah.
They have the unit, but I don't know that they want to deal with it.
Yeah.
And it seems to me, well, I know the French place is closed down for horses, so that's out of the question. The Animal Health Trust in the United Kingdom closed down. Liverpool closed its radiation unit when I left.
Is it because of lack of resources or?
I don't know.
Or politics?
I think it's politics and red tape, because whenever you're dealing with radiation, you have to have very special facilities. You have to be able to put the animals into a certain environment. But historically, it took a long time to treat them with radiation, because you use low-dose iridium wires, intralesional wires, and latterly we use HDR now. The low dose was 10 days or in the box with a wire sitting in it. That used to be done for prostate cancer in particular, but also some cervical cancer and stuff. And the wires were shaped accordingly, and so those were implanted. But then people used to walk around with their wires and walk around all over the kingdom, radiating everybody. But they don't do that anymore. They use HDR now.
Yeah.
And HDR is a mechanism putting the wires in, and then putting a huge dose of radiation in immediately. Very well planned and very well constructed application, and then 5-10 minutes, maybe 15 minutes later, take them all out again, and the horse just goes home. And the tumors get better, and I've seen lots of these, and when it was available. But it's not, and that's not good. It's not good. It has to be. We have to be better, because radiation is the gold standard. You see? And that gives us as near 100% as we can get. Usually, out of my nearly 500 cases, 400 and something cases that I did at Liverpool, we failed in 3, I think.
So it's.
But some of them needed 2 lots. Some of them needed multiple treatments. Some of them just. And the 3 that failed, I know why. At least we have an explanation. So whilst it's not 100%, and it never be 100%,
but it's still quite a high
as near
success.
as we could measure the other treatments by, and all the other treatments are less effective.
So to wrap this up, what would be your practical advice or your take-home message in regards to sarcoids to horse owners?
Detect them early. Look at your horse on a regular basis. If you find little areas of skin changes that don't look right, wherever they are, but more particularly in the sites where sarcoids develop, in the armpits, around the face, around the eye, and in the groin, ask your vet. Contact your vet and say, what is this? Okay, and hopefully you will say, I think my horse has a sarcoid, but ask them, because there may not be a sarcoid, because each of the types of sarcoid have a different set of other conditions that could be involved, and that's not always easy to separate them, but vets with experience can do this, and it's all Swiss study. The Swiss study from Bern was amazing, and they proved that vets were very good at making the diagnosis without taking samples, because if you take a sample from a sarcoid, remember, you're interfering with it, and you have to be ready to do something. You can't just walk away. Okay, you cannot walk away. And furthermore, you only walk away from a sarcoid if you yourself personally are going to walk away from your own cancer. And I don't think we're going to do that, are we?
No, for sure not. But we are lucky to be in Switzerland, where we have good vets for that.
Absolutely.
Thank you so much, Derek, for your insights.
That's a pleasure.
Thank you for joining us and Professor Derek Knottenbelt for this fascinating conversation on equine sarcoids. If you've enjoyed this episode, don't hesitate to share it with a friend or a colleague who might benefit from it. And make sure to follow PKN Podcast on your favorite streaming platform so you don't miss out on future episodes on equine health and well-being. Until next time, thanks for listening. Learn more to care better.